Okay, so this looks like it's a good case to do a walkthrough with, to be honest with you. So let's paint the big picture and do a walkthrough and how we would analyze it and put it together. Is that okay?
Yeah, that sounds good.
Okay. So let's start with the end and go, okay, what's the bare minimum 7 categories that we need to support a good case? So we need mechanism of injury, subjective, hybrid, and objective findings, at least one primary in each of those categories. And then we need MMI, then we need impairment rating. That gives us to the prognosis and need for future care. Now, what would be nice to support a case is if we also had complicating factors, injury magnifiers, and complicating factors. And then if there was any other residual factors, neurological weakness, things of that nature. And if there was any surgery, anything like that, even minor surgery or even medication. So let's walk through and see where we're at. And let's start with let's go to mechanism of injury first. So do you remember the mechanism of injury?
This one was a rear end. Rear end, he was at a complete stop.
You know if he had his foot on the brakes or was the car rolling? The reason I ask is sometimes they'll say it's a complete stop and it's not really. They're either still rolling a little bit to come to a stop, or they're rolling to get going. Usually it's not a total complete stop. And the reason that I make that differentiation is, remember, when it's a total complete stop, and especially if they have their foot on the brakes, the friction just significantly increased, which absorbed the energy, which decreases the energy going into the occupants. If it was moving, even if it was rolling to a stop, or rolling starting, you have that much less friction. That means more energy is being transferred into the occupants, or the higher probability of an injury. That's an injury magnifier. So I get very clear when I talk to the patient, were you at a complete stop, or were you rolling toward the end, or were you rolling forward, and did you have your foot on the brake? Now, if they had their foot on if they were totally stopped and had their foot on the brake, I'm just gonna mark it, but I'm not gonna put any emphasis on it at all. That doesn't help the case at all. But if he's rolling to a stop or rolling starting, that's an injury magnifier. We got less friction and more energy is going into the occupant, and that's why I asked you that.
Gotcha.
Okay. So
Yeah, I don't know. From what I gathered, his foot was on the brake. I didn't ask a specific question though.
Okay, these are the things you're going to be obviously start to pay a lot more attention to.
Yeah.
Okay, and then of course the big 3 injury magnifiers. So it was hit from behind, so you got a whiplash effect.
Yeah.
Car was stationary, and then was his joints locked out? Was his head turned, looking to the passenger in the rearview mirror?
His head wasn't turned. He didn't see it coming though, so he didn't brace. But yeah, his head wasn't turned. So
Okay, so you've got a whiplash of the top 3. Those are typically the top 3. So of the top 3, you got a whiplash and you got defenses down.
Yeah.
Okay. What about how hard was he hit from behind?
Other car was going roughly 30. He estimated 30 to 35 miles an hour.
And remember, you always want to confirm that on the accident report.
Yeah.
So that's a pretty good jolt, 30 miles an hour. And then was there any type of weight differential in the vehicles? The type of car what type of car was he in?
I would have to look at the file to see, but I do think there was a weight differential.
And I look for about, if there's a 20% different in weight differential, then that's when I'm going to include it.
Okay.
Okay. Now when I say 20%, they're 20% greater than the victims.
Gotcha.
If not, I'm just going to document it, but I'm not emphasizing it.
Gotcha.
Okay. Did he have a seatbelt on?
Seatbelt was on.
Okay, that's an injury magnifier. Did he have a headrest up?
I didn't ask that.
Okay. There's a laundry list of the injury magnifiers that we always have them check off. Just make sure you follow that laundry list. I listed about 14. There could be 15 or 16, especially if you include a congenital defect, but there's at least 3 main ones, but I would say about 14.
Okay.
So these are the main ones. And so he was hit from behind, 30 miles an hour, car was stationary, weight differential, defense is down. Okay, so he took a pretty good impact.
Yeah.
We got a lot of energy. So we've got anatomical failure, we've got force equals mass times acceleration, and we got coefficient of friction is not going to play a role. So we do need to know about the headrest, the seat restraint. Did he have airbags?
Had airbags, they didn't deploy.
Okay, that's not good. So the seat restraint is a injury magnifier. Most attorneys get that wrong. It saves lives because it stops throwing people out of the car, but the injuries have increased because the restraint throws them into anatomical failure faster. So you have a lot more comatose people and severe injuries and less deaths with seatbelts. That's what happened with seatbelts. So you got to be able to explain that. No. Okay, so we got several injury magnifiers. And by the way, let me just cut to a question you asked earlier, and then let me get back in line. You said, is it bad to have a high impairment rating? Well, would you rather have, if you had a choice, would you rather have a high impairment rating with low supportive findings, or would you have diverse supportive findings with a lower impairment rating?
Yeah, definitely diverse findings with a low rating.
That's what's most important. And if you have a high impairment rating and you don't have high quantity and quality and diverse findings, now it looks fake. So if you don't, it better be a lower impairment rating, unless it's like ridiculously obvious, like they, their arm was amputated, something like that.
Yeah.
Okay. All right. So we got mechanism of injury. They were the driver, right?
Correct.
Was anybody else in the car?
Nope, just them.
How old are they?
Roughly 38.
Okay. Not
Late
young,
30.
not young, but not old. So right in the middle there.
Yeah.
All right. When you took his x-rays, did you see any other complicating factors, spurs, degeneration, anything like that?
Facet hypertrophy in the lower back.
How about the neck?
Neck, loss of cervical curve was the only thing, but no other complicating factors.
All right, that's good. And then you did the static and motion studies, right?
Correct.
Okay. All right. So we got mechanism of injury. We got like primary and secondary injury magnifiers. And then what's his subjective findings at MMI?
Still low back pain, radiating to the right hip.
Which one bothers the most, the neck or the low back?
The low back.
Oh, is that right?
Yeah.
Okay.
Yeah. So his neck complaints, they were at MMI. They weren't significant. But
does he have any neck symptoms at MMI?
He still does have some spasm.
Okay. Does he have any symptoms?
No.
He's got no neck symptoms at MMI.
No.
Okay. Remember when that happens, when you ask them, say a scale of 0 to 10, and they say no, what's the next thing you do? You take them into the dynamic plane of motion of the injury and ask them again. Because remember, they're answering it from you from a neutral position or from altering their behavior. And remember, they forget how they alter their behavior over 3, 4, 5, 6 months. So as an example, if I said let's say they're in the MMI range, and I say on a scale of 0 to 10, how's your neck? They go, oh, no problem, 0. My next question is going to be, and I knew it was a whiplash injury. I said, well, how about if you bent your head all the way back as far as you can? Now where are you at on a scale of 0 to 10? I'm gonna take it into its dynamic motion all the way to the end play. in the plane of motion of the injury, because that's ultimately the last thing to clear up, right?
Yep.
So that's called high sensitivity testing. You're being way more specific than just neutral. Can you see how they'll answer you in the neutral position typically?
Yeah.
Okay, so you got to be aware of that and ask for that. Okay, so let's leave the neck and say there's not much there. And then you say he does have low back pain at MMI?
Correct.
Any other, you said he does have radiating. Is it in the legs?
It radiates into the left side. Doesn't go all the way down, but goes kind of mid thigh. So it goes into the buttock and mid thigh.
Okay. And he had an MRI showing a disc bulge.
It's 2 disc bulges.
Oh,
2.5 and 4.5 millimeters.
2 different discs.
Yes.
Was there any associated degenerative changes around those discs?
Just the facet hypertrophy.
Okay, well that's good because that's more strength. If there's no degenerative changes, which shows he was pretty much healthy, and then he gets in this accident, next thing you know, he's got 2 disc bulges. That helps to eliminate the pre-existing injury call. Okay.
Would somebody argue that due to the facet hypertrophy, you could say that he had, I know there's no bone spurs or anything like that, but would that be a valid argument that the facet hypertrophy?
Yeah, sure. Yeah, remember they should argue everything that you do to support the case. They should counter it. There should be something for that's a good attorney, but that's not the norm.
Yeah,
you'll typically have them attack you on 4 different areas, generally speaking, and that's about it. But everything you do should be attacked in some form or fashion if you had a good attorney, and even if it's acknowledging it, but trying to minimize that component. Because they're trying to decrease the percentage of liability. It's not black or white. They're just trying to decrease the percentage of liability.
Mm-hmm.
So, but that won't happen in low impact soft tissue spinal injury cases. You won't find good attorneys like that. When you start dealing with high value money, now you're going to run into good attorneys that will go after you for everything. Okay, so we've got, let's just keep following the path here. So we got mechanism of injury. We've got our injury magnifiers. We've got subjective. Any secondary findings in the low back? So he's got pain and radiating into the left. Anything else in the low back?
No.
Constipation, bowel, bladder, nothing?
Nothing.
Okay. So we got low back pain and radiating pain, and you said it to the left hip down to the knee or thigh?
Yes.
Okay. All right. So that's the subjective findings. So that's pretty solid. So let's come over to the hybrid findings. What would be the most common hybrid findings that we would probably see? Well, let's walk through the checklist and see if you did it or not and what you got. So is active range of motion diminished in any plane at MMI in the lumbar?
Yes.
Which you would expect it to be, right?
Yes.
Which same with overpressure. So now you know he's got overpressure and graded out. He's probably a 3, at least in the plane of motion of the injury and overpressure, right?
Yeah.
Okay. And now we have so that's active and passive range of motion. When we go to muscle strength, did you do any muscle strength analysis at MMI?
I did very little. I did strength testing with the legs. So he didn't have on the left side, he had a little bit of decreased strength. I would grade it as a 4, but nothing on the right side.
Okay. I would think that they would have. And remember, again, if they don't at MMI, then you should put your finger or thumb on the spinous process of the motor unit and push on it and retest their muscle strength again, because if they were 100% healthy, they'd have normal strength. So that's a high sensitivity way of evaluating muscle strength. But if he's got a disc, you could that type of disc involvement with active range of motion, you can almost be sure he's going to be a grade 4. So I need to document that. And then I need to document all the categories, L3, L4, L5, or L4, L3, L4, L5, S1. So I need to document each of those individually, the flexors of the hips, the knee flexors and extensors. First, the hip flexors are extensors, the knee flexors are extensors, and then the foot dorsiflexors are extensors, and then the big toe. So you got L3, 4, 4, 5, and S1. So just make sure you've documented those neurological components, and then which one are specifically involved, and then it's probably grade 4. And you could see it more unilateral, which would help the case even more. If it was unilateral, that would even show contrast. Okay, so that's muscle. We go to neurological. Now, with neurological, when they have any types of radiating pain, the very next thing that we should have done is we should have sent them out for a neurological consult to a neurologist. Now, that really helps support the case. And all you do is that's all you do is you tell them you're just asking for their opinion. Say, hey, we'd like a neurological consult. It has tingling and radiating into the left thigh, and then send them a copy of your findings, and that's it. In other words, we let that professional be a professional. You don't try to do everything. That's when chiropractors get in over their head. And then you leave it up to them. And he's probably going to run an NCV and an EMG, probably, just like you probably would anyway. Now, most of the time, those are normal. You know that, right?
I do know.
Yeah. They're typically normal because they're testing a different pathway, acute versus chronic pain pathways. So that's why you can have tingling and numbness, positive orthopedic findings to reproduce it, and a normal NCV. That's why. So it's really, really rare to have a positive NCV or EMG, but it is standard of care. So it's not like you would not do it. Matter of fact, I guarantee you, if you sent him to neurologist, that's what he'd do. But the neurologist would help to confirm. Now, remember, he should already be a team member, because you don't send anybody who's not a team member. In other words, you've already met with them and you've already said, hey, just don't say anything bad about chiropractic and don't take them out from under care, and I'll be glad to refer you patients. So when you have a team member like that, then he knows, even if it's a normal NCV EMG and the patient has symptoms and radiological findings reproducible with orthopedic test unilateral, it's pretty easy for him to confirm that he's got a radiculopathy, and a statement of radiculopathy from a neurologist is way more important than a chiropractor. Would you agree?
Yeah, I would.
Okay. So that piece of the pie is missing, right?
Yes.
I'd get on that. I'd send them out for a neurological consult to a neurologist who you have a relationship with.
Yeah, I have to find one. I don't have one.
And call down to the local MRI centers. They already know who the people are, who the paraprofessionals are, who typically are involved in personal injury.
Okay.
And are typically willing to sign a letter of protection. That's the first place you want to look. They've already been in the game decades, and so they already know who the players are. Okay. So that's what you want. You definitely want to get that up and going, because it'd be really nice for this case for you to have a neurologist in his professional opinion that this patient suffered a radiculopathy as a result of this accident. That would be very powerful.
Yeah.
Okay. Next, go to orthopedic findings, go to primary and secondary. So we'll probably have positive Kemp sign, right?
Yes.
You probably have positive intrathecal signs, Soto Hall, Bechterew, or Milgram's.
Interthecal.
What?
I said, what is intrathecal?
Disc.
Okay.
This just is a intrathecal sac, the disc.
Okay.
And so what are the common ones? Sodal Hall in the neck, Milgram's low back, sitting Bectorus I really like because it really stretches the whole cord top to bottom.
Okay.
So if you don't have that in your protocol, make sure you put it in there.
Okay.
And as well as Valsalva.
Yep.
So you probably have Valsalva, you probably have Milgram's, you probably have positive Bectorus. If you don't, get it. And then
Yep.
you know to grade it. It's not just positive or negative. Grade it 0, 1, 2, 3. Because the guy come off the table when you do it. Use the functional capacity scale with your orthopedic test in addition to positive or negative. That takes us next to palpation. So you would typically have some positive palpation, right?
Yes.
Okay, same thing. You want to grade it with the functional capacity grade scale. When you go in there, does it come off the table? He probably, jumps back enough to try to get you to stop. That's a grade 3. Identify the motor units involved, and they'll typically correlate with the disc, right?
Yep.
You see how all this is coming together?
I do.
Okay. All right. So and then same with fixation. You're going to have fixations there just from the intrinsic muscle spasms, if anything, right?
Yep.
So identify the location, quantify the fixation also, grade 1, 2, 3, tells the severity. And then next one is muscle spasms. So typically you'd have bilateral lumbar erector muscle, extensor muscle spasms. So that's palpation. Now let's go to x-rays. Now in the x-rays, we would have done the Davis series in the neck, but we would have added, and did you add, cervical AP, left and right lateral bending, checking for rotational malposition. And did you add the APOM, left and right lateral bending?
I didn't add that one.
Okay, you want to do those with your trauma patients. Now,
You say rear end collision, because I was thinking more so for a collision.
It's not likely, but since it's over 20 miles an hour, the typical low impact injury is under 20 miles an hour.
Mm-hmm.
So a lot of stuff starts looking crazy once it gets over 20 miles an hour.
Yeah. Okay.
So just because of the magnitude of the impact is why I would do it.
Yeah. And even though he says his head wasn't turned, if it was even a little bit, that could affect it.
Yeah. Now let's go to the low back. Now, this particular case, I'm going to definitely do the flexion extension lateral view on, which is unusual because that's where we're going to look for ALMSI in the low back with flexion extension. And I'm going to do it because it's 30 miles an hour. He wasn't going 5 miles an hour. Yeah. And he's got the disc and he's got the radiculopathy. So I'm definitely going to be doing the flexion extension views. And I'm going to do, obviously, the neutral views, and then the lateral flexion views. But you may have a good chance of finding ALMSI because of that disc bulge in flexion or extension, either translation or angulation in one of these motor units. Now, you remember in the low back, ALMSI is a little different. It's not consistent because as you get further down, the lower lumbar lordosis increases significantly at L4, 5, and S1, right? Mm. So at L1, 2, and 3, it's pretty much the same, the measurement. And then L4 to 5, it's a little bit increased. And then L5 to S1, it's a greater number. It's like 4.5. Yeah. The numbers are a little different. But I would definitely do the flexion extension. Now, what's going to be your problem with those x-rays? How hard is it going to be for you to get an overpressure x-ray with somebody who has a disc bulge?
Yeah.
Is that something he's going to want to do?
No.
So what do we have to do to get this finding?
I'm not sure.
We got to drug him up.
Okay.
So we explain all this. So I need him on some serious, when I do this motion study, I need him on some serious analgesics, some pain prescription, and I may even need, depending on the severity of it, I may even associate with my pain management doctor to do some trigger point therapies to relax all these muscles and the pain, so I can check the integrity of these ligaments, because he's not going to let me, is he?
No.
He's going to scratch your eyes out.
Yeah.
And then if I did that, I'm also going to do some weight bearing. So if I'm going to go ahead and stretch those ligaments to measure them, I'm going to add an extra, 5 pounds when I go forward or backwards to really pull those bones as much as they'll pull, to really check that integrity of that ligament. Since I'm going to be injecting them or giving pain medication thereof. But this is a typical case where I'd get with my pain management doctor and I'd let him know what we're doing, but his intrinsic muscles and pain is not going to allow him to go into overpressure to let us check the integrity of the true lesion. He's going to protect the hell out of himself. So I'm going to let him know how this works, and then I'm going to coordinate it with my pain management doctor, let him know what's going on, say, is there any way we can do some facet injections and prescription analgesics right before we do these motion studies, so I can get a true representation of his ligamentous integrity? And since I'm going to do it and I'm doing drugs or shots, go ahead and add an extra 5 pounds on to really pull it all the way over into flexion, or all the way over into extension, or all the way over into left lateral flexion, or all the way over into right lateral flexion. You just have them hold the weight. Sometimes there's weights. There's like weights with straps on the head, but when it's the low back, you can just have them like hold the weight and bend forward, hold the weight and bend backward, hold the weight and go to the left. You just have them hold like a 5 or 10 pound weight, depending on how strong they are.
Yeah.
But since I'm going to be doing drugs and giving them a shot, I'm going to weigh them down, because I'd hate to do it and then go, well, I'd like to do it again, because you're real close to MLSI. You'd probably get there if you were medicated. So, but I would definitely be doing it on this case because of the magnitude of the case, the degree of the impact, number one, and 2 disc bulges as a result of it. Because you already know, once there's a disc bulge, the likelihood of AOMSI has significantly increased.
Yeah.
And that's way more. And now you have 2 major diagnoses, not one. And now you're going from a 12 to 15% impairment, low back disc with residuals, to a 25, 28% impairment. That's the difference it makes. So I'd have all the diagnosis. So if I found the ligament, I'd put it in there, whether it was flexion, extension, translation, angulation, even left or right lateral flexion malposition. I'm going to document it, because he's got every associated finding: active range of motion, over pressure range of motion, orthopedic tests, x-rays, palpation, fixation, tenderness. You see how everything's lining up.
Yep.
Now we're just driving it deep. We're going, okay. So that's the low back. That's x-rays. You got the MRI. And then I definitely want to do Dynarom. What's the likelihood I do not have muscles firing normal? I don't.
Yeah.
So I'm going to have another third-party objective finding. I mean, this is a big case. Just from the objective standpoint, you're going to have a positive Dynarom. You're going to have positive x-rays with AOMSI. You've got positive MRI with disc bulge, 2, not 1. And you got radiculopathy, and you have every associated finding from mechanism injury, the multiple injury magnifiers, two primary and secondary orthopedics tests, fixation, tenderness. You see how this thing is getting overwhelming?
Yeah.
This is how you put the cases together. Okay, so I'm going to do the blood test too. What's the likelihood if he's got two disc bulges that he's got some organic internal inflammation?
High.
So I'm gonna substantiate that with blood tests that are 100% objective. So I'm going to make sure I do see reactive protein in the sedimentation rate for inflammation. So now how many objective categories? We got 4 totally different diagnostic objective categories. We got actually 5. We got MRI, X-ray, blood test, Dynarom. You got 4 major objective findings supporting this case. Guess how willing I am to go to court to tell this story.
There, yeah.
This is a slam dunk. Okay. Unless there's some weird stuff going on, some extraneous stuff, was he drunk or did he pass out or, other things that would mitigate. But let's say there's no mitigating circumstances. Okay. So we got all our fine. And then we would do an NCV EMG, but the neurologist would do it. So now you have a medical radiologist correlating the disc. I'd take the X-ray, send them to the chiropractic radiologist for the ligaments. Then I got the blood tests, which are 100% positive. Then I have the Dynarom, and I'm going to have them read it. You always want them to read it, not you. That it's a third party person that's reading it, not you, which is important. And they only charge $100. You just put that in the LOP, but also they'll testify for free if it goes to court. That's why you want them to read it, not you.
You're saying with the Dynarom?
Yes. So you got 4 major positive objective findings here. 5 if you include the blood test. And then you've got the associated hybrid findings, subjective mechanism of injury magnifier. So I probably will not have a positive EMG, but if he's a team player, I want him to say that in his opinion, that the radiculopathy is a direct result of this accident. That's what I want him to say. And you already have all the associated findings. You got mechanism of injury, subjective findings. You got the hybrid findings that correlate with the radiculopathy. By the way, some of those other tests, orthopedic tests in the low back, would have been Lesegs, Braggart's, Patrick Faber, SI compression, some of these other tests that would be secondary tests. But the big ones would have been the intrathecal findings and palpation, fixation, tenderness, muscle spasms with the X-rays and the MRI and the Dynarom. Those are your big tests for the disc.
Gotcha.
Okay, so we've got all this thing locked up pretty good. Got our injury magnifiers. Do we have any complicating factors? Most complicating factors, the most common ones are people have to work. They have to do stuff for a living. Or they may get fired or terminated or reduced. Okay. So, and then was there any other complicating factors like diabetes? Was he a smoker? Less oxygenation to the tissue. And then we talked about pre-existing in the low back. You said there's hypertrophy in the facets in the low back?
Yes, he is a diabetic as well.
Oh, okay. That's a big complicating factor. That's a big complicating factor right there. Okay. So you got all that documented. So you got quite a bit. You got mechanism of injury. You got injury magnifiers, multiple. You've got subjective findings at MMI. You got multiple primary and secondary hybrid findings at MMI. You got 4 major objective findings that all correlate at MMI. That takes us to MMI. Let's go to the impairment rating. So with him, I'm going to suggest that he probably has LMSI. You just need to find it and document it. So he's going to be up there around 25% impairment rating. And I want to point this out to the attorney that if it was a disc with no residuals, he'd be at a maybe 6% impairment rating. With residuals, radiating pain or muscle weakness, which has 2 residuals, he's going to be up around 15%. That's with a disc. But with ALMSI, it takes it up to 25. He's going to be up there around 25%. See, the attorney doesn't know what I just told you. You're the one that has to explain this to him. You're the one that has to explain to him the 7 major categories and all the supportive factors that you have in all of these categories. In other words, exactly what I'm doing with you. You need to share this with him to show him how good of a case he has and all the documentation you have to support it. Okay. So let's say we have that impairment rating. Now you can't do both. You can't give LMSI and a disc impairment rating. It's the same anatomy. You got to pick one or the other. And you always pick the one that's the worst. But in the diagnosis, he's still going to get the LMSI diagnosis as well as the disc diagnosis. All the diagnosis he's going to get. So but he only gets one impairment because you can't overlap.
Gotcha.
Now, what's interesting is, remember in the low back, I'm also going to look for facet impaction. Remember, you draw McNabb's line under each vertebral body. Does the inferior facet rise above it? It probably is in the same motor units that were involved. Now, the reason I point that out to you is that will give you another 1% whole person. Same with abnormal lordosis. Now, at what percentage would I call his lordosis pathological, whether it's hyper or hypo in static position? Well, with him, I'd say 20%, but I'd even go as low as 10% just because of the magnitude of the injury. So if it was 10% off of normal, I'm going to call it pathological because of the magnitude of the injury and the supplemental findings. So now, why is that? It's a secondary finding. It supports everything else, and it's 100% objective. And when you come over to the impairment ratings, remember when you come over to the range of motion table, for structural anomalies, you get 1% added. So if I got McNabb's, or if I have in addition, and if I have abnormal lordosis, then that's 2 more whole person impairment ratings that I'm going to add to 25. So it'll be at 27. And in all likelihood, this is exactly what's happened with this patient. Everything I'm telling you.
Yep.
You just need to get it.
Gotcha.
Okay. Now, so you got good. So in this, let's say we got all this great documentation. You got multiple categories, multiple diagnostic or objective categories. And you got the impairment rating. And remember, the 2 most important categories is was there a permanent impairment rating, number 1, and number 2, how did it cause pain or restrictions with activities of daily living? So now I got to be really good at loss of enjoyment of lifetime activities and duties under duress. It's because now I'm documenting the ADL restrictions. And that is what's important in life, is when people have pain or restrictions that are permanent with their activities of daily living the rest of their life. Well, we already know he's got permanent findings. Now we have to associate those and document them with his ADLs. How do we do that? It's called the loss of enjoyment of lifetime activities index and the duties under duress index. Now, remember, the loss of enjoyment of lifetime activities is more of his perception in all of these categories. How does he feel about his loss? So it's his perception. Now, when you go into duties under duress, now we're going to pay a lot of attention to all of these categories. And what I'm going to pay attention to is not just active range of motion. Remember, that's when you'll get a lot of false negatives. You'll get a lot of positives with him anyway, because he's got restricted gross range of motion and MMI with disc bulges. But I'm going to go into every one of these ADL categories, and I'm going to ask them specifically. I'm going to say, I don't want to just do it in neutral position. I'm going to ask him about that activity. Can he do that activity 100% with his low back? So as an example, if it was mowing the lawn, say, do you have any pain or restrictions with mowing the lawn? So whatever it says. Say from any time you start from mowing the lawn to the time that you finish, all the activities it takes in between, those are dynamic activities. Mowing the lawn is not static. Some parts of it are static. I need to pay attention to the dynamic components and bring that to his consciousness and match that with his injury. And I'm going to pay attention to the overpressure dynamic component with the plane of injury. So like in his case, let's say his plane of injury is mainly an extension in the low back. So I'm going to go, so when you go into mowing the lawn, from the time you pull the lawnmower out to the time you twist it, to the time you start it, to the time you push it. In other words, everything that's involved from the time you start mowing that lawn to the end. Do you have any pain or restrictions? And can you do it 100% with your lower back if it was all the way bent backwards? In other words, I'm going to take his back and put it all the way into the dynamic motion that he should be able to do 100%, not just static. And I'm going to tie it to that activity of daily living. That's how I'm going to get a yes or no. And then I want to quantify. And I'm going to quantify it with the functional capacity index 0, 1, 2, 3. Now you're going to have to write that in because they don't list it. They just say gardening. So you need to put in there whether it was active or passive range of motion and grade it.
Okay.
That's how you get all these findings. And you're overwhelmingly going to look for the plane of motion of the injury. That's where you're going to have all the findings in overpressure. So that's where all my talk is going to lead to, and through the whole timeline of the event. Not just I'm thinking about mowing the lawn. It's from him thinking about it to actually doing it in neutral position or general motion. And then in some of those components of mowing the lawn, there's going to be some overpressure involved to some degree with his plane of motion. So in that whole activity, you may only find 1, 2, or 3 areas that are positive because that's the only areas that involved that plane of motion and overpressure. Now, if you didn't ask it the way I just said it, you just got a normal. In other words, if you just had him check it, he would just look at it and go mowing the lawn. He'd go normal because remember they don't think in terms of dynamic motion. They think in terms of static. So you have to take them there. You have to mentally take them on this journey into that activity of daily living and all the components relative to it in the plane of motion of the injury. That's what you're trying to measure because that's the absolute last piece of healing, is it not?
Yeah.
Okay. And then quantify it. Can you still do it? Does it bother you? No. 0. Can you still do it? Yeah. Does it limit you from doing it? Yeah. 2. Does it stop you from doing it? Yeah. 3. Functional capacity index. Now, when you do that, I've got everything lining up in my loss of enjoyment and lifetime activities and duties under duress that totally correlates with my mechanism of injury, subjective, hybrid, and objective findings. You see how strong that is?
Yeah.
Okay. That's your documentation. Now, you know how to point out that evidence in the minimum 7 categories, but like I told you, you got an additional complicating factors and you also have injury magnifiers. Now, what else we got is you'll pay attention to the other stuff. Did he take off time from work? Did he use bracing? Did he use medication? How much and how often? You know, those are important secondary documentation.
Mm-hmm.
But you've got more than the 7 categories to fulfill this case, and you got more than one level of primary documentation. Some of these categories, hybrid and objective, you got multiple categories of primary documentation and secondary documentation. So you got a stacked case.
Yeah.
Then you go, well, that takes you to the next question, which is how do you convert this into 4 injury awards? Well, let's go to when you go to medicals, we're gonna determine the medical injury award based on the science of the 3 phases of healing. What were the biomarkers that you found for pain or inflammation? What were the therapeutics you did to help decrease the pain or inflammation? What was the frequency that you did it, and what was the cost? Add all of that up. That's the cost for the inflammation phase for medicals. Then you're going to come over to the repair phase. You're going to do the same thing. You go, okay, what positive findings did we have? Now, remember, the goal there is to increase active, passive, and joint motion. Well, you got all kinds of findings in active, passive, and joint motion. So what therapies did you use? What was the frequency that you used them? And what was the cost? Add them all up. That gives you the cost for the repair phase. Then you're going to go to the remodel phase and do the same, or the remodel phase and do the same thing. You've got the findings for that. For now, you're looking at to increase strength and elasticity. What you got all the biomarkers for it. What therapeutics did you use to help try to get that back to normal as much as possible? Whether it was PNF, chiropractic adjustment, whether it was TheraBands, whether it was the Pedibond ball or whatever it is. And then you go, same thing. What was the frequency? What was the cost and the duration for the remodel phase? Add all that up. Total all 3 together, and that's what supported your medicals. Now let's go to impairment. And remember, impairments can vary depending on where you're at. A lot of times they will correlate with workers' compensation. But typically, when you're looking at impairments, a real simple way to quantify it is what was their income between the time they were injured and the time they met MMI. And that would be your impairment injury award. Then when you go to pain and suffering, it's the same amount, but now it's magnified on a scale of 1 to 5. 1 to 5 is the degree of the injury. Real severe injury, you'd magnify it times 5. Real low, you'd magnify it times 1. So now you got real quantifiable numbers, their income, and then we're just going to tie to it a magnifier. And when we associated it with all our findings, mechanism of injury, injury magnifiers, multiple subjective, hybrid, and objective findings with primary and secondary findings. So in this case, I'd be going for close to 4, even 5, because of all that supportive documentation times their income from the time they were injured to the time that they hit MMI. And then I'm going to go to prognosis and need for future care injury award. So when I hit MMI, what was the therapeutics that were needed for palliative care? Because remember, at this point, that's all the prognosis and need for future care is about. It's palliative care, having them feel better, decrease pain, muscle spasms, tension, that kind of thing. So what's a common scenario? Well, with this one, it would be real easy to suggest definitely pain. So he probably would be on some kind of prescription medication from my pain management team member, because he should have been referred to pain management for medication. That's who takes care of the medication, is the pain management doctor. So he should have that. What was the frequency that was needed? Well, that would have been gotten from the pain management doctor. Well, how long do you think he's going to? Well, that's determined at MMI. What was needed at MMI? Because remember, you always want it to be based on them, not your opinion. And it's based on them when it's based on all their biomarkers. So what medication was needed, whether it was over the counter or prescription? What was the therapy that you were doing that was needed for palliative care, pain, muscle spasms, inflammation, whether it's chiropractic or muscles or some type of muscle work or passive range of motion, just whatever it is you did. Typically, it's chiropractic adjustments with the joints, the nociception and the pain, and the how it affects the muscles. So you can add in over-the-counter medication, add in chiropractic. You're probably talking about some type of muscle therapy, whether it's massage or whether it's muscle stim, something You're doing something to help with pain during the remodel phase. And then I typically throw in, I like to throw into that mix osteobiflex. And the reason I like to throw it in is because it's 11 herbs and supplements that are all anti-inflammatory with no side effects. So he can take that the rest of his life and not eat out his gut from prescription medication. And then you go, now I know what therapies. Then I go, well, what frequency did they need him? Well, what frequency was he on with his care when he hit MMI? That's the frequency that you put him on. So whatever palliative care was needed, whatever frequency was needed at MMI, that's the starting point. Because now that's not your opinion. And then, and you know the cost for all these, so you know the cost, the frequency, and what was needed. Now the attorney needs to go to the actuarial scale, not you. You're supposed to stay clinical. As soon as it goes over the money, that's the attorney, or you lose credibility. So, and you have to tell the attorney this. Let me give you this, this, and this, and then you multiply it times their actuarial scale. So the attorney goes to an actuarial scale and figures out how long he's going to live. And then he multiplies the frequency of your care at MMI, the cost of your care, times his lifespan. And that's why typically it's the largest of the 4 injury awards also. That's how you supported all 4 injury awards from a total objective quantifiable analysis, not some screwball opinion.
So after,
and by the way, the attorney doesn't know what I just told you. Matter of fact, once you give him enough certain information of all this documentation, he's going to turn to you and go, well, what do you think I should ask? And that's how you go. So now we know each of the 4 injury awards, you total them all together, and that's what he asked for, and that's what you can support if you went to court. That's how you do personal injury.
So if we can go back to the prognosis and need for future care, let's say at MMI, we're seeing them. Let's say I'm still seeing them once a week or twice a week. And they're going to live for the next 30 years, approximately. Are we estimating that we're going to still continue to see them twice a week for those 30 years?
Yeah, it's permanent. As a matter of fact, it's going to deteriorate and get worse. Is he going to get better?
No.
No. It's going to deteriorate and get worse, and that's going to be in your narrative report and deposition, and that's called the phases of spinal degeneration. He's going to go downhill fast. The frequency and the amount of therapeutics are going to increase. His gross range of motion and overpressure and gross range of motion are going to continually decreasing as the frequency intensity of pain starts to increase. All of these things start going downhill fast. And then we justify the need for future care supported with the spinal phases of degeneration, and then point out which phase he's in. But then also you're supporting everything I just told you based on the science of the 3 phases of healing. So we can explain why he has pain when he doesn't move. When he doesn't move, it's because of his fast and slow twitch nerve fibers. The slow twitch nerve fibers were damaged, and that's why he has chronic pain when he doesn't move. When he moves, that has to do with your fast and slow twitch pain fibers, but now it has to do with it's either from phantom pain, but that's not true. We're not dealing with phantom pain here, or we're dealing with nerves that are they've healed wrong and they're hypersensitive, or we're dealing with nerves that have been that there's an increase in the number of nerves in the same confined area, but when he moves, that area gets smaller and squeezes them mechanically, or those nerves are getting trapped in the scar tissue. That's what's causing his pain, whether he's static or dynamic. That's why he can be totally pain-free in a neutral position, or totally pain-free in the first 30 degrees, But as he goes up to 40 degrees, it starts getting he starts feeling the pain, and it starts getting worse fast because of what I just shared with you about the science of the three phases of healing from the neurological standpoint. I just explained why they have pain or discomfort, either stationary or dynamic, or with excessive motion, or why they have no pain, maybe with some motion, and then it starts to get worse as they increase that motion, especially in a certain plane of direction, because you already know he's already gonna have more trouble in the plane of the injury.
Yeah.
So that's the three phases of healing that support it. That's why we use that for our therapeutic protocol, our therapies, our response to treatment, why we explain why we did what we did, why we quantified what we did to see if they were getting better or staying the same. That's why we identified what phase of healing are in. That's how we identified when they were at MMI. And that's how we identified medicals, the impairments, pain and suffering, and the need for future care. And none of that was your opinion.
So what I'm realizing is that the prognosis and need for future care, I've been undervaluing that quite a bit, because I've been putting it over, let's say the next 12 months, as opposed to doing an actuary scale or having the attorney do that.
Well, if it's 12 months, they're not at MMI and they should still be getting treatment. MMI means permanent the rest of their life, not 6 months, not 12 months. It's like I had a chiropractor one time. He did the same thing. He gave pain and restrictions for 3 months. I said, "How did you pick 3 months?" He goes, "Well, I'm kind of embarrassed to tell you now." I said, "I understand. Well, why'd you tell me?" Because that's what my friend does. I said, "Don't ever say that again in your life."
Yeah.
MMI is permanent, and it just goes to, I don't know about you, but I don't know how many injuries are problematic at MMI that actually go away and get better.
Yeah.
Have you ever heard of that?
No.
I haven't. They always deteriorate and get worse.
The need for future care. Yeah. So I wouldn't. So I guess the question is, if I'm putting that inside of a report, am I just going to state the frequency, or am I going to put a dollar amount to it?
Well, it's a combination. Remember, there's multiple things you're putting together. Number one, they're at MMI. Number two, what palliative care was needed at MMI?
Okay.
That's the palliative care you're starting with. And then what frequency was it needed at MMI? That's the frequency you're starting with. Now you're just going to add to that the cost. Well, you already know the cost of your therapies. Your part is done now. Now it's turned over to the attorney, and he goes to the actuarial scale, multiplies all what you just gave them, multiplies it times their lifespan. And then they will typically add in inflation to it.
Okay. So I guess what I'm giving the attorney, should I give them like, this is the cost that it's gonna be per visit? Is this the cost is gonna be for a year's worth of care, or is this you see what I mean? Like what number?
You're giving four things. This was the palliative care needed at MMI. What was it? Itemize it out. Okay. Number two, this was the frequency that they needed it at MMI. Number three, this was the cost of the therapies. Those are the three things you're given. You're done.
Gotcha.
Now, believe it or not, you actually have to educate your attorney, because they'll ask you, and little do they know that that's not good for you to be answering that, because now you've crossed a line into moving away from a doctor and being an attorney in front of a jury.
Yeah.
So you just stick with the things that you should know as a doctor. You should know the palliative care that was necessary at MMI based on their biomarkers. You should know the frequency of palliative care that's necessary based on their biomarkers. You should know the cost. You're done. Now,
Gotcha.
Now it's an administrative function, not a doctor function.
Gotcha.
You turn it to the attorney, and then he'll go to the actuarial scale, take your three data points, multiply it in 30 years or whatever, and then typically add in inflation. That's what they'll do.
Gotcha. Okay. So I can, okay. Yeah, I like
Now,
doing it that way.
believe it or not, you have to actually educate them. What I like I'm helping you. This is what you have to do to them. They don't know. Again, it depends on what type of attorney we're dealing with. You know that by now, right?
Yeah.
Okay. But even the I guarantee you, even the Trial Lawyers Association would watch this film and learn a lot from it.
Yeah.
Even though they know a lot. That's how it's done. Now, you know how to do that. We teach you how to do it. That's what you do. You put it all together. How much sense does it make? How much sense does this make?
Makes a lot of sense.
Okay. Now you were a chiropractor prior to joining me. You joined me and you're learning all this. What percentage of this did you know prior to joining me?
Ooh, let's say 25%.
And you probably up that number more than what it is. And here's my point. That's your competition.
Yeah.
And you are even trying to pay attention to personal injury.
Yeah.
You have no competition whatsoever.
Yeah.
This material we just covered tonight with this case, this knowledge base, and how to logically and sequentially put it together. There's nobody. You're the attorney. I just took you through it. Where do you want to send your cases now? To Joe Schmo that's putting cervical sprain strain down with no impairment, no prognosis?
So it's yeah. It's funny you say that too, because so the attorney that I met with on Friday, we talked quite a bit, and he said, I actually want to send you the notes that I get from the place that he usually refers to. And so he sent them to me and I read over them. They have 3 facilities, but it's all sprain strained. It's none of this stuff. There's no substance to it. So yeah.
You're in a dangerous position right now. And here's why it's dangerous. You could go in with what you did. Here's what happened. You said enough to stir his interest to get him to ask you for your opinion.
Mm-hmm.
Okay, so you said enough. You probably did not do a sales presentation, though, did you?
No.
Okay, but you knew a few triggers, right?
Mm-hmm.
Okay, so he sent them to you. So guess what's the worst thing that can happen right now? You half-ass it and not do a sales presentation and put it all together.
Yeah.
You better come back. In other words, the very next step for this person is to have a total, complete sales presentation, not half-ass. And then remember, at the end of the sales presentation, we always give an offer, a financial driver checklist, to see what documentation is missing from their case that's going to hurt or limit their injury award. So he's already kind of asking you to do that, but you're not going to do it half-ass. Now you want to totally do the sales presentation and get it right, nail it, and then do the financial driver now, and don't wing it. Walk over, set it up, take the checklist with you, and go through 2 of his cases one at a time, and go through all the documentation that's missing and use the checklist. Now, I just followed the checklist with you, but I knew it from memory. What's the likely you're going to remember the checklist at this early in your career, learning personal injury?
Very likely at this point.
You better let me tell you, even though as much as I know, I never go over to the attorney without the checklist. As much as I know and I teach it.
Mm-hmm.
I'm not stupid. I know I will forget stuff that I need to remember. So I still today, when I do a case evaluation, I walk in with that checklist, even though I teach it.
Nice.
So that's where you're at right now. You're in a real position to know enough, but not seal the deal.
Yeah.
Because right now, you could really nail this thing shut if you switched it to the presentation. Don't come back with him with this checklist yet. What you need to do now is do the presentation and nail all the categories, and you got to get him to admit how much money he's losing. That's the number one thing that you have to get to establish need. You got to get them to admit how much money they're losing. So to some degree, he has a need for him to ask you to look at it, right?
Yeah.
But can you see how on a scale of like 0 to 10, maybe his need might have been a 3, but after you finish with the sales presentation, it's off the chart in a 10?
Yep.
That's where you're at right now. So I'm just telling you, don't do the wrong thing and half-ass it.
Yeah.
So you need to, so don't go over there. Don't do the checklist yet. Do the presentation. Get him to admit how much money he's losing. Then offer the checklist, and then use the form and literally go through the checklist with the form. And then whatever they did not do, you have them send to your office to do all the things that they didn't do, the hybrid test, whatever they didn't do.
Mm-hmm.
Remember, it doesn't matter if it's positive or negative. What matters is you know the categories and you know how to document it or not. So don't worry about it if it's positive or not. That's not you. Don't worry about it. What's important that they know is that you know how to document all these categories and how to put these categories together if the patient has them or doesn't have them. Because they want somebody that also knows how to tell them they don't have a case. Because they don't want their ass out in the wind.
Yeah. So
that's what you do, is then they come over, you document everything that was missing, then you put it in the 12-step narrative format. That's what tells the story that supports the case. Then you come back and you meet with them. This is how you become the authority now. This is how you get to be, the main guy. The first part sells them. Now this part sells them on you.
Yeah.
And then you show them what was missing, remind them what was not done, show them all the categories you did do, show them what was positive or negative, and show them the narrative report, how you tell the story to put it all together, and then remind them how it's converted. Then you tell them what kind of a case he has, because now you should know of the 7 minimum categories, how much documentation you have. Well, in this case, you have a lot. And then you should be able to explain to him how to convert your documentation in those 4 injury awards, like what I just did with you.